Good afternoon, everyone, and welcome to the Fletcher Group Rural Center of Excellence's webinar series. Today's presenter is Geoff Wilson, a licensed clinical social worker, licensed clinical alcohol and drug counselor, and certified clinical supervisor with more than 30 years of experience in mental health and substance use treatment. He currently practices with Lexington Counseling and Psychiatry in Lexington, Kentucky, providing services to adults, adolescents, and families. A respected clinician, supervisor, and trainer, Geoff has held numerous leadership roles in behavioral health and professional associations and has been a sought-after trainer for more than 25 years. Geoff, the floor is yours.
All right. Good afternoon, everybody. I want to welcome you all to the presentation today, Co-occurring Disorders and Recovery Support. And again, real pleasure for me to be here with you all to talk about such an important topic. And to give you a sense of what I wanted to cover with you today, we'll talk a little bit about the prevalence and severity of co-occurring mental health and substance use disorders, kind of looking at a snapshot of what that's like. And then get into the importance of not only the impact of the disorders on the client, but what presents as barriers sometimes for effectively engaging clients that are struggling with co-occurring disorders. And then we'll wrap up talking about some best practices for intervention and treatment and in recovery environments too, some important things to really consider in trying to help clients that are struggling with co-occurring disorders. And please, if you have questions, make sure to put those in the chat, and I'll be more than happy to answer any questions you all have at the end of the training. So I know many of you are familiar with this, but just for the presentation at hand, the coexistence of both a mental health disorder and a substance use disorder is referred to co-occurring disorders. And again, this can include any combination of two or more substance use disorders and mental health disorders that are typically identified in the DSM-5 TR. And again, no specific combinations are uniquely defined as co-occurring disorders, whether that is major depression, generalized anxiety, ADHD, and alcohol use disorder, methamphetamine use disorder, or personality disorder or something like that would be defined as co-occurring disorders. One asterisk on that too, a lot of our clients also are going to have medical issues, and the importance of ensuring that we're ruling out any type of medical issues that can oftentimes present and cause symptoms that very much can manifest and look like a mental health disorder is super important to make sure we do that for our clients. A couple of interesting aspects with this that not everybody typically considers. With co-occurring disorders, symptoms here of substance use disorders in patients with a mental health disorder, uniquely, the reinforcement that somebody gets from a substance that may have post-traumatic stress disorder, major depressive disorder is very different than someone that does not have an existing mental health disorder. There's been a lot of research that's shown that the payoff that somebody gets from an opiate or methamphetamine or alcohol is more enhanced when somebody has a co-occurring disorders, which means that's going to typically impact their ability to enter into recovery and move in that direction, just simply from the payoff that they get from it. That also contributes to mood swings and more issues with mood change for an individual versus those that may not have a pre-existing mental health disorder. Their tendency to look for escape is much more significant, to feel hopelessness, definitely prevalent. But these last two, I think, are also really important as well. The client that has PTSD, that has generalized anxiety, bipolar disorder, their ability to, as far as judgment, tends to be more negatively impacted with their substance use disorder than somebody that may not have a mental health issue. Conversely, too, inability to appreciate consequences, we know because of just impact on brain function, we'll talk a little bit more about that, tends to be more prevalent with the person that have co-occurring disorders. So that's really important to consider as you're trying to address the needs of your clients. Now, flip the coin, results of substance use disorder with a mental health disorder. Those individuals that, I have an addiction and there's the prevalence or presence of depression, bipolar disorder, PTSD, what do we find? Typically lower medication adherence. I have a couple clients right now that oftentimes they will stop taking their mood stabilizer, their antidepressant, and of course that makes them at a much greater risk for relapse. So we tend to see a higher return to use rate with clients with co-occurring disorders. That also means, too, the exacerbation of mood swings, depression that might lead towards suicidality, panic. So the need for more as far as inpatient, residential treatment, more significant levels of care typically. And again, clients that may end up struggling with homelessness, joblessness, really some more significant psychosocial stressors. Not uncommon to see that with clients with co-occurring disorders. So very important to consider that. And these are common issues. Looking at SAMHSA's 2024 National Survey on Drug Use and Health, a huge survey we do every year. This is one of the more recent ones in 2024. Over 21 million adults had a diagnosable co-occurring mental illness and substance use disorder. We know that from insurance billing, Medicaid, Medicare billing, and diagnosing what treatment centers, outpatient, IOP, partial, residential submit. So that's important because keep in mind, that's just the clients we know about. There are so many more out there that will never meet us. They never actually get an official diagnosis. So there's a pretty significant treatment gap that exists that unfortunately makes it a little bit harder to interact with those clients and try to provide them with some services. So those individuals struggling with a mental illness, they just are at a higher risk of developing a substance use disorder. And I see that a lot with clients I work with that once I start doing an assessment and ask, hey, talk to me about when you first noticed an issue with your mood, not uncommon for them to talk about around middle school or maybe early high school. And then their substance use came after that, so the self-medication piece of that is usually really prevalent. At the same time, those that start using, especially using at a younger age and start to experience everything that comes along with that, are going to be more vulnerable to develop primary conditions and chronic diseases. We just know that. So medical issues like depression, anxiety, opening situations to where trauma may come into play, they're going to just be at a much higher risk. So this slide just looks at some of the more common co-occurring disorders that I've touched on already. And one that I think, especially in higher levels of care, like inpatient, detox, residential, short and long term, and definitely recovery environments, sober living, we'll see clients that have post-traumatic stress disorder, along with perhaps even major depression or anxiety disorder, along with methamphetamine use disorder, opiate use disorder, nicotine's there, alcohol, variety of different substances. And that makes it really, really a challenge to kind of look at, okay, what's going on with this person, and without a good period of sobriety, where we can like let everything settle to really accurately diagnose somebody, that's a big challenge. Over the years of working in different treatment environments, I've seen a lot of clients come in that are misdiagnosed. And trauma, especially an individual that's experienced chronic trauma, which repeated trauma, and complex trauma, so trauma done to me by a loved one or somebody that's in a position of authority, very much more prevalent than people realize and tends to have a really significant impact on the person. I'm going to share with you, just want to veer into that a little bit around the importance of treatment environments, understanding the impact of trauma and being trauma informed and moving toward that is really a good move and something we should strive for. Claudia Black, who's been a guru in the field forever, and I know a lot of you are familiar with her, but if not, I'll just put two or three of her books there that are phenomenal. But this quote from her: if we're chronically dysregulated long enough, we tend to become stuck in a dysregulated state, regardless if the original pain is still present or not. That's a lot of our clients. A lot of our clients in treatment that have not had the opportunity or have even recognized themselves the need to address how this is causing them to continue to struggle is really significant. Most of us just day to day, we have our autonomic nervous system and we'll go through periods of arousal and periods of decreased arousal. And almost 50 of you are here in this training right now and taking a breath, listening, paying attention. You're kind of in this period and we deal with little stressors throughout the day. But for the most part, we're in our window of tolerance and it's an optimal arousal zone. We're present, we're open, we're curious, we're alert, and we're relational, interacting with our coworkers. That's not a lot of our clients. A lot of our clients tend to be more like this slide. From when their head comes off the pillow to when it goes back on, they may spend a considerable amount of the day being in a dysregulated state, which you look at the top there, sympathetic hyperarousal. So clients that are walking around anxious, restless, hypervigilant, exaggerated startle response, impulsivity, poor judgment. This is a client, I'm ready to go. I want to quit, AMA, struggling with house rules, things like that. But at the same time, they're also experiencing, you see at the bottom there, parasympathetic hypoarousal, flat affect, depressed, lethargic, self-loathing, hopeless, full of shame. I'm doing treatment wrong. What's wrong with me? Typically very isolative. So if we're not aware of this, we're not continuing to assess for it and treating it, that can be really significant for our clients as far as their ability to even engage in treatment and participate. So just super important to make sure that we're screening for and assessing, not just in the very beginning, but throughout their treatment, as hopefully a client is gaining sobriety to determine what type of impact, if this is present, is it having on them. Yeah, and this is from Claudia Black here too. The more severely we're dysregulated and or the longer it lasts, the greater the chance we subjectively experience unbearable discomfort and difficulty staying within our own skin. And that there's that old expression, the best part about sobriety is to get my feelings back, and the worst part about sobriety is to get my feelings back. Here's this person with 40, 50 days sobriety that's coming out of their skin, having night terrors, really struggling with sleep, barely is able to engage, but then other times is doing pretty good and looks like they're doing well and feels okay. And they're just kind of ping-ponging back and forth with that. And then they discharge and then they go back home or they return to an environment that's not healthy with a lot of triggers, and their risk of returning to use is super high. This slide, real quick, I'm just going to share with you because, looking at so many of our clients that have experienced adverse childhood experiences, ACEs, and another reason why a really good screener to give clients is just an ACE assessment. Have you met the criteria for any of these things? The slide you see there on the left is what we would want every 11-year-old's brain MRI scan to look like. The slide you see on the right is an 11-year-old male with chronic post-traumatic stress disorder that experienced over a 2-year period pretty consistent physical abuse. What you notice there is some significant impact on brain functioning. Okay. And you look there kind of in the center, where on the left-hand side, it's nice, even triangles. Whereas on the right, this kiddo's midbrain limbic system is pretty significantly impacted, which means much greater chance for impulsivity, difficulty with managing emotional states, much more likely to be impulsive. And because that's a part of our brain that has the most to do with managing stress as a human being, their normal experimentation with a substance is going to be very different, the reaction they probably get, than somebody that has not experienced this. The other thing I'll mention, there's a few things here, but it's super important. On the left-hand side, you see a nice thin white band around that kiddo's prefrontal area. And on the right, you see a much wider band, which means this kiddo on the right has experienced brain atrophy. His prefrontal cortex has shrunk as a result of his trauma. And that's a lot of our clients. I mean, a lot of our clients, they have had significant impact. And prefrontal area is stop, think, and act. It's the part that weighs out pros and cons. Should I do this? What may happen? So this individual is going to be much more impacted and probably struggle with, slower to return to a baseline. It'll take them 45 minutes, an hour to kind of calm down. And that ability to weigh out pros and cons usually is going to be impacted. Now, a body has amazing recuperative abilities, especially if we leave it alone and nurture it and give it things like sobriety, good diet, hydration, psychiatric intervention if needed, and stable environment. And that's where recovery housing, sober living can play a huge part of that in early recovery, where people can make great strides and address some of the issues that have occurred as a result of trauma. Let me keep going here. And long-term effects, unfortunately, what we find, and we've seen this in research and especially with adverse childhood experiences, people are just at a much greater risk to develop high-risk destructive behavior. So alcohol and substance use, depression, anxiety, suicidality, STDs, heart disease, skeletal fractures, just a much greater risk. So those clients that have experienced 4, 5, 6, 7 adverse childhood, there's a really good chance that we need to look at trauma, the potential that they do have post-traumatic stress disorder, and are we treating it effectively? Which also brings in trauma-informed care, understanding that environments that are informed with this usually interact with clients in a way that's going to be much more empathetic, genuine, taking into account what they've experienced. It'll help recognize issues that may exist in the environment that potentially could re-traumatize somebody. So some core concepts of that really starts with everybody being informed about the prevalence of it, number one. Number two, how it affects people, some of which I've shared with you guys, but also is our whole treatment system informed, trauma informed? Are our individual practitioners trauma informed? Are our peer supports trauma informed? Is the person that answers the phone trauma informed? Is the person that admits the client trauma informed? If not, any one of those individuals can potentially be a roadblock for somebody to engage in treatment. And then we want to take all this information, actually put it into practice, which is a big part of programs being trauma informed. So a great first step with that, just presume that every person in your environment that you're helping has been exposed to abuse, neglect, violence. We're going to do much better with them. We're going to understand that things like my tone of voice, my cadence, the environment will have an impact on people. And especially if somebody needs some type of psychiatric intervention, medication management services, things like that, that not only are we able to offer a medical assessment ongoing, but a prescriber and somebody that can treat them throughout their not only their stay in care, but when they discharge as well, which is hugely important. So, with that, looking at the history of our field with treating co-occurring disorders, we didn't start off the best. We've done much better, but unfortunately, when we go back into the history of the addiction treatment field, typically what we saw was sequential treatment, which is I get referred to one form of treatment, I'm treated, and then if hopefully I get referred to another form, and then I get treated for that. So I'm struggling with my mood. Somebody says, "Hey, let's assess you. You seem depressed. I'm going to prescribe an antidepressant." But that person doesn't realize I'm drinking 6 glasses of wine a day or a fifth every 2 days. And you might as well be giving me a chiclet. Conversely, I might go in for treatment for my alcohol use and everybody's like, "Hey, just get sober. Your mood will get better. You'll feel better. You just need sobriety." And I discharged after 2 weeks, and everybody wonders why I go back to drinking because I'm severely depressed, but nobody's treated it. That still happens some today. When I came into the field in 1993, 94, 95, we were doing parallel treatment. I would go over to this building to see the mental health therapist. I would go over to this building to see the certified alcohol and drug counselor, and I would go over to this building to see the medication practitioner, and heaven forbid they all talk to each other. Now that happens a lot today and can be very effective if people talk to each other. If we have releases of information and the nurse practitioner is talking to the certified alcohol and drug counselor that's talking to the mental health therapist. The goal, what we want to strive for, and I think this is where over the last couple of decades we have done much better, is moving toward integrated dual primary treatment. Some of you all may be familiar with Kenneth Minkoff, who's kind of the godfather of the integrated model of treatment for people with co-occurring disorders, where he was one of the first people to say we need to treat these as both primary, both need the same amount of attention. Okay, so diagnostic specific primary treatment for both. And preferably, I can do that in one building or in one environment, or people understand the importance of making sure I'm seeing my substance abuse counselor, I'm going to see the doctor, I'm seeing my mental health practitioner, or like myself and several of you all, I can provide both for this person, and our nurse practitioner is right down the hallway. So we talk regularly and the client knows that. We're working in collaboration with them. That's going to be much more effective for clients. Yeah, provided both in the same place, providers and treatments that have varied backgrounds. So, a lot of experience with this, cross-trained clinicians that understand there's a lot of waxing and waning with symptoms. People are going to perhaps need to try a different medication or two or three before they find the right one. And they also might need different types of psychosocial rehabilitation to address things like arrested development and different stressors that they have in their life, all of which can impact somebody's potential to return to substance use. So, a couple other things good for us to keep in mind. A common cause of psychiatric relapse is resumption of alcohol or drug use, not misuse, not abuse, not dependence. Somebody with co-occurring bipolar disorder, with alcohol and opiate use disorder, and there they are with 43 days of sobriety, and on a Saturday night, they go over to a friend's house and they smoke a joint. Okay. They wake up the next day, the world's still spinning, everything's all right. I must be able to do that. They do it again the next day. And then on the third day, they stop taking the Risperdal. And then there they are a week and a half later and they're in serious trouble. And that all started with that Friday, Saturday night. Conversely, a very common cause of relapse to substance use is untreated mood disorders. Clients that there they are at day 14, 23, 32, and they're maybe not sharing exactly how they're feeling. We're not screening for it, we're not assessing it, and they are very anxious, they are very depressed, and they return to use because their brain is kind of sending a message of this is as good as it's going to get, and they'll return to use. Couple other things that complicate this. Let's take opiates, for example. And I know you guys are familiar with this, but post-acute withdrawal for a fentanyl addiction can last 2 to 3 months. So 64 days later, I still have uncomfortableness in my stomach. I still get leg cramps. I'm still sometimes not feeling the best. And that's just as a result of my substance use disorder, which is depending upon how my mood is really going to exacerbate that. So another thing that's important for us to keep in mind. So with that, with our clients, and whether you're an outpatient provider, inpatient, residential, sober living, recovery support environment, clients will present in different fashions with different levels of co-occurring disorders. So several years ago, SAMHSA and the National Institute on Drug Abuse came up with a model for addressing co-occurring disorders called the Quadrants of Care model. And this is something I've always found really helpful for me as an outpatient provider. When I have a client come in and they sit down with me and I start to do my assessment, I will immediately start to think, what quadrant are they in? And as you look here, you see four different types of clients based on substance use severity, low or high, and mental health disorder severity, low and high. Okay. And you see there's four quadrants. Quadrant one, low substance use, low mental health disorder. Quadrant two, low substance use, high mental health disorder. Three, high substance use, low mental health. Four, both are high level. Well, could that look like? Quadrant one, and I tend to see a good amount of quadrant one clients that are referred from a primary care physician. I have generalized anxiety and I'm consuming too much alcohol. I'm working, I'm functioning, but I'm having 2, 3 glasses of wine during the week. And on the weekends, maybe it's 4 or 5, and that's starting to affect my mood. And I don't realize it, but it's actually exacerbating my anxiety. Okay. A quadrant two client, they may present to primary care, but they may also present to an IOP mental health program. Okay. They have bipolar disorder. They might have PTSD or bipolar disorder, even with psychosis, and they drink a little too much. They're using cannabis to help manage their mood. That might actually be making it worse. They may occasionally take Valium that they bought on the street, something like that. But they're not addicted to fentanyl. They don't have methamphetamine use disorder, a more chronic medical issue. Quadrant three, now let's flip that. Fentanyl, methamphetamine use disorder, PTSD, bipolar disorder with psychosis, or I'm sorry, quadrant three, higher substance use. So yeah, again, fentanyl, methamphetamine, significant substance use, but lower form of mental health, an adjustment disorder, social phobia, something like that. Now, a lot of you all treat quadrant four clients. So schizophrenia, antisocial personality disorder, PTSD with opiate use disorder, methamphetamine use disorder, multiple substances. And within these quadrants, they're the locus of care. Where do they come from? We want to consider that. Quadrant one clients typically come from a primary care type setting or outpatient treatment, family practice physicians, nurse practitioners, things like that. A quadrant two client, more severe mental illness, tends to come from the mental health system. They present, perhaps they were assessed in an emergency room or maybe a psychiatric hospital. They didn't need inpatient treatment, but they were maybe need a more like an IOP level of care or a partial hospitalization level of care. Quadrant three, less severe mental health, more severe substance use, they tend to present in the substance abuse treatment system. So this is going to be a client that might present at a detox unit or an inpatient rehabilitation center, something like that, a PHP program that's going to need a psychiatric intervention as well. Quadrant four, not uncommon for them to have contact with the legal system. They may be arrested for a charge, AIPI, DUI, assault, something like that. They may present to a state hospital or, again, an emergency room and then get referred to a higher level of care. I share this though because it's helpful to keep in mind, who am I treating? Where are they coming from? And for me to recognize that these are both primary, regardless of the severity, I need to pay attention to them. I need to make sure every time I meet with the client, I'm always asking, how's your mood? How's your sleep? How do you feel? What's your diet like? I need to assess these things along with their substance use, craving, sobriety, anything else associated with it, we would typically address in treatment. So again, just a different way, but I think a helpful way to consider, who am I treating? So I'm going to take you through 6 guiding principles for treating clients with co-occurring disorders, and then we'll wrap up a little bit after that. I just want to highlight a couple things with this, but that first one you see there, employer recovery perspective, understanding, and I know you all do, it's a long-term process and there's changes throughout this. So the client that presents to your safe sober living program that might have a pretty good period of sobriety, understanding there's still a high risk to return to use, there's still a high risk to have an exacerbation of their mental health symptoms. So we want to have treatment plan goals that are going to address that over a long period of time. We want interventions to not only help move them from an action stage of change to a maintenance stage of change, 4 to 6 months of sustained change or longer. And that's important for us to keep in mind. Whether you are working in detox, if you're an outpatient provider like me, we're all kind of planting seeds to help them get to the next level to continue all along early recovery, which is typically the first year. 12 months from now is still considered early recovery for our clients, which also means it's important to adopt a multi-problem viewpoint. So many of our clients have an array of psychosocial issues. So the more that we can continue to address those, like housing, employment, healthcare, and continuing to treat everything from endocarditis to wound care to hepatitis, things like that, treatment, supportive networks, understanding too, so many of our clients, rehabilitation, a client going to rehab implies I had a skill set, I got away from it for my substance use, and I'm trying to get back to it. So many of our clients, this is habilitation. I never acquired the skill set. I'm a 36-year-old female client, but my age of onset of use was 12. So you may think that you're doing adult treatment with this client at 36. You're probably in some ways doing a little bit more adolescent treatment than you realize. Now, with that, recovery home environments, residential treatment too, are really beneficial. And, those that are very well structured, they provide a lot of support and they can help address some of these stressors like housing and work and employment, can really be a huge bonus to their treatment and really help them move toward longer term recovery. So I kind of view this, and I know a lot of people do, that the recovery home environment, sober living, is probably some of the most important pieces because we're getting to a point where we're trying to move them towards independence and ensure as much as possible that we do everything we can to prevent a return to use. Number three, developing a phased approach of treatment. And understanding that for both mental health and substance use, clients are going to go through pretty predictable phases with those. And a lot of that starts with the first time we meet them, engagement. That part, engagement enhances motivation. So if I'm engaging them and we're screening and assessing them early on for mental health and substance use, much more likely they'll move to the next phase, which is stabilization. And if we can get through that, we're going to start to get to where active treatment can really begin. They can probably get into the program a whole lot more and move toward eventually aftercare and continuing care. But also, keeping in mind for both issues, mental health and substance use. And if we keep that in mind and we're focusing on that, we'll do a good job with our clients. Number four, another guiding principle is address specific real life problems early in treatment. Interventions that target important areas of client need. Now, I might think that this certain thing is important for that client. That doesn't mean that they do. So me taking them where they are, what's the most important need for them is really significant because solving problems reinforces engagement. Okay, solving problems reinforces engagement. You help me with housing, that's a big deal. I'm much more likely to stay involved. Employment, huge deal, much more likely to stay involved. Recovery support, people in my corner, and I feel like that, much more likely to stay engaged. So, psychosocial habilitation and rehabilitation, helping me with things like living skills, communication skills, is really important to enhance my treatment. Number five, plan for clients' cognitive and functional impairments. I'm going to talk to you just a little bit and touch on it. I mean, there's a much larger 6 hour presentation I do, but because we see so many clients that struggle with methamphetamine use disorder, there's some very specific things about that medical issue where this comes into play. So many of those clients, because of the impact it's had on them, cognitively, there are impairments. So I'm speaking to you guys like this in this format for 50, 55 minutes. If you all retain 15% of this, 20%, that's pretty good. Okay. And if I come find you a week later and you've maintained 5 to 10% of it, that's excellent. Our clients, when we ask them to sit in a 3 hour IOP group and just listen, if we think that they're actually going to retain that, we got another thing coming, because again, because of how much their brain has been compromised from the impact of methamphetamine, it's just really, really a challenge for them to retain that, which is why we need to do things like gradual pacing, visual aids. So not only you're going to hand me some things that I can look at, but I'm going to look up at a board. I'm going to get up and walk up and write things. I need repetition, a lot of repetition. That's going to be very helpful. And as part of screening and assessment, we need to make sure that we really look at any deficits that a client may have, whether that's learning disabilities, intellectual developmental disabilities, different aspects that they may really struggle with that, gosh, goes back to when they were children. Okay. We don't always do the best job of that. And then number six, using support systems to maintain and extend treatment effectiveness. And I know a lot of you all do this, but again, the old phrase, opposite of addiction is connection. So if we want to enhance engagement, having opportunities for clients to get involved in AA, NA, double trouble groups are great. If you don't have those in your area, NAMI is the group that can help establish a double trouble group where the expectation is I will attend this meeting and talk to you about my bipolar disorder, my Depakote, my Risperdal, and my methamphetamine use disorder. I'm supposed to do that in those groups. Okay. Can't do that as much in an A or NA group. What about supportive family? Let's get them involved. What about faith? A lot of clients want to maybe move back and reestablish a relationship with their faith. That can be a huge deal. Understanding that clients that have more prevalent co-occurring disorders tend to burn bridges with programs, with family. So we, clinicians, peer supports, clinical managers, case managers, play a pretty big role in guiding clients toward available support systems. Recovery home environments are an excellent source of enhancing this, encouraging it, and being a part of it. So that environment with who's working there, their ability to connect, to be trauma informed, encourage sponsorship, those can make a really significant impact on the client that has co-occurring disorders. Another way to think about this is it is very much the dental model of care. And what I mean by that is most of us are going to go to the dentist this year. We're going to go next year. We're going to go the year after. We're going to go the clients with co-occurring disorders. Oftentimes they will always be involved in care. It's just going to vary depending upon exacerbation of symptoms and the severity. I've got clients that they may see me twice a year because they're stable, they're doing well. I saw a client on Monday. He's taking his medication, he's doing great, great sobriety. he had a very strange family dynamic thing happen. He's good. I probably won't see him again for a while. Conversely, he could have a return to use and exacerbation. I may see him weekly, and he may see his prescriber 2 or 3 times over 3 months and then be stabilized and might not see him for a long time. It's good to understand that is a goal. That's a good goal. And the more clients that have co occurring disorders understand the importance of continuing to see their providers, they're going to typically do better. And kind of gets us back to integrated parallel phases of recovery, where you look at acute stabilization for mental health and substance use, motivational enhancement for both, active treatment for both, preventing not only a return to substance use, but an exacerbation of their mental health, and recovery rehabilitation, where the interventions are not only diagnosis specific, but specific to that stage of change that they're in. And it's important to keep in mind, too, clients, they'll be in different stages of change with different things. Some clients will really struggle to accept that they might have major depressive disorder or PTSD or bipolar disorder. A bipolar disorder, especially, is one where oftentimes you have a client that when they start to experience mania, they like it and they'll stop taking their medicine. But before you know it, they've returned to methamphetamine use or cocaine use. Or when they get really down, their brain will do its job, which is don't forget what makes me feel good. And that will encourage them to return to substance use. Almost always, though, they've either stopped taking their medication or they maybe have missed doses. And that's played a role in that, which is really important. It's also good to keep in mind and to assess this with your clients, recovery and relapse thinking. All right. And I've had a lot of clients over the years when they've had a return to use or exacerbation, they'll kind of talk about, well, I may as well, I might as well, I'm here, I might as well. No, hold on a second. I want to shift you into every day considering it matters what you do. It matters what you do. Okay. Where you go, who you're with, the phone calls you make, the treatment assignments you complete, your attendance, your participation, what you eat, how you sleep. It matters what you do. Um, Recovery thinking versus relapse thinking and acting out, the difference between those two. Abstinence violation effect versus I'm going to stop taking my meds. I don't need them. I want to be sober with everything. And it's like, well, hold on a second. Just like if I had diabetes, I mean, I need to treat that. As much as I'd want to just snap my fingers and say I don't need to, I'm going to be in big trouble. Major depressive disorder, bipolar disorder, PTSD oftentimes are very similar with that. So, yeah, reinforcing to clients, it matters what you do. And I touched on this a little bit earlier, but I just want to circle back to it because, again, clients that you're working with that have methamphetamine use disorder, understanding that level of impact and the severity of it. Mark Gold, who's been in the field for a long time, I was fortunate to see him at a NADAC conference probably 7 or 8 years ago. And he did an excellent presentation on methamphetamine psychosis and its similarity to schizophrenia. And he put up a couple of brain scans looking at here's a client with chronic methamphetamine use disorder, and here's a client with schizophrenia, and they're almost identical. And understanding from a treatment provider standpoint, who am I working with? And is it realistic to think that one kind of treatment is going to address that for everybody? So we need to look at and have modalities and interventions that are much more tailored to address clients that may really be struggling cognitively with emotional deficits and with co-occurring issues. So what would we want to keep in mind? We are all in this training neuroplasticians. Part of my job is to enhance neuroplasticity because that's recovery in the brain. So we might want to consider moving away from, hey, I want you to sit in a group and listen to me for an hour and a half, take a break and listen to me for another hour and a half, or watch something for 2 hours. For, you know what, we're going to start the group with 10 minutes of walking around, of being outside, of moving. Then we're going to go into a 15, 20-minute didactic where I might have you come up to the board and write things down, every client, or fill out an index card that you're going to share. And then we're going to have a question and answer period. Well, a client is going to be much more likely to remember that. When you look around and half the group's falling asleep after that, that's a part of it. Okay. So that I encourage people to kind of think about. Do we need to look at addressing treatment with who am I, how are they impacted, And that's just looking at the substance use. We have to consider a lot of those clients have a co-occurring mental health issue. Executive functioning, anything I can do to get the brain firing and establishing neurons and getting it moving back to a recovery orientation. Things like jigsaw puzzles, crossword puzzles, computer games, not necessarily the violent ones that demand attention. Okay. Um, Treatment programs, recovery housing programs, they can even have competitions with that with clients. And that actually gets them into getting their brains to recover because they're firing in a different way versus they're sitting there watching a movie. Okay. Not the worst thing in the world, but is that really going to help with brain functioning enhancement? One of the best things we can do for our clients is have them engage in physical exercise. Can they break a sweat daily? Mark Gold kind of touched on that. Getting our brains to fire, get the body in shape, the mind will follow premise. And everything from walking, shooting hoop, lifting weights, it can be a variety of different things, ropes courses, things like that, but also interaction with other people. So AA, NA, Double Trouble, sponsorship, establishing therapy, anything that enhances relational abilities is going to be preferential for clients with co-occurring disorders. With being neuroplasticians, what's something else that enhances plasticity? Novelty. Okay. Our brains, all of us, lights up for novelty. It's why we want the new phone. We want a new Apple Watch. We want a new this. We want a new that. We want new shoes. That's our brain reacting to things that are novel. Okay. Boring treatment is not treatment. So I need to have things that are going to engage me that are novel. Role playing is novel. Getting up and moving is novel. Getting clients to write stuff on a board, fill things out, do things that are not just sitting and listening. Physical exercise can be novel. Mindfulness activities, meditation, wonderful thing to do. Guided imagery. Those are really great things that you can add to your treatment environment that are really helpful because it does some important things. It reduces rumination, boosts working memory, and helps with stress reduction. Clients are going to be much less likely to have emotional reactivity. When I first got in the field a long time ago, this was probably 1995. I had a supervisor at the time, and I was working at a minimum year-long residential substance abuse program. So you imagine had to be there for a year. And he said, Wilson, residential treatment's easy. Keep them well fed and tired, very tired, which is why all those clients 6 days a week were involved in 1 day, 1 hour of weightlifting, followed by an hour of group activity, skill building activity. And it made a world of difference for them. Relationship satisfaction, huge health benefits for our clients. Okay. Um, so, before I wrap up, and want to make sure looking at everything we've covered here, prevalence of it, important aspects to consider with mental health and substance use, integrated treatment, specifically trauma-informed care environments, steps that we can take towards enhancing that if you already have it or adding it are usually really beneficial for clients with co-occurring disorders. And a resource I just wanted to pass on also to you all. This is the Tip 42 manual from SAMHSA, Substance Use Disorder Treatment for People with Co-occurring Disorders. It's a great resource. Some of what I've shared with you guys comes from this. I use this a lot with my supervisees. And here's the thing, it's free. Okay. So you can get one sent to you, you can download it. But I encourage you all to check this out because it is a really good resource that definitely focuses on the topic at hand. So yeah, and then I've got a list of references and resources here for you guys too. So I wanted to make sure we left a little bit of time. So we got about 10 minutes for any questions. So I'll be more than happy if anybody has any they'd like me to address. So just let me know.
All right. Thanks, Geoff. I was just looking, if anyone has any questions, feel free to drop those in the chat or the question and answer. A couple of things that I was thinking about. So also being an LCSW and running an intensive outpatient treatment center and working a lot with recovery houses, this whole thought around trauma-informed housing is we went from not doing trauma-informed care to sort of implementing trauma-informed care into treatment practices. And now sort of the next leg of that is implementing trauma-informed care into housing. So thinking about that and working, especially with co-occurring folks, as you mentioned, they typically have a lot of traumatic events in their background.
Yeah.
How can thinking about those rural folks that may not have a lot of resources right handy to them, how can they implement some trauma-informed approaches when they have a very limited access to clinical staff on site? So do you have any ideas or thoughts around things they could do to use trauma-informed care in recovery houses?
Yeah, yeah. And Amy, that's a great question. A lot of it really starts with basic education for clients about the impact of it. My experience has been oftentimes when I would start to bring that up or address it in a group, I might be one of the first people to actually talk to them about that they have a co-occurring disorder. That's the first time they've heard that. But I think there's a wealth of information that's out there that's available, including from that tip manual that can be presented from an educational format. It doesn't have to necessarily be master's level or individual LCSW, LPCC that can get clients considering and thinking about, hey, it's not that there's something that's wrong with me, but something happened to me, which is usually a really big shift for a client to understand something happened to you that you really didn't have a lot of control over. And that may right there just start to kind of change how they view themselves. That can be delivered in a group type format or kind of a process type situation, and usually is a really good place to start. And then just ensuring that the people that are working there move toward understanding trauma too, and that a lot of the clients that are there perhaps are struggling with it. But that's a great question.
All right. Thank you. The other thing so as I was running an intensive outpatient center, and we worked a lot with recovery houses, you talked in the beginning about silos, right? And how treatment tends to be siloed. And I think I'm from Idaho, and Idaho treatment is still very siloed. So
Hmm.
go see my mental health provider over here. I have my substance abuse provider over here. I live in a recovery house. Thoughts or ideas on how oftentimes I think recovery houses feel sort of left out of the communication wheel.
Yeah.
Any thoughts or ideas of how recovery homes or houses or support providers could work more closely with treatment providers and sort of be a part of that continuum of care instead of sort of being that secondary ancillary piece on
Right,
the
right.
outside?
Yeah, and that is much more common. And unfortunately, my experience has been you almost have to have somebody in the recovery home environment that's kind of like the designated person that will be the link, that they know that's their role is to reach out, make sure clients fill out releases of information, have that contact, make sure that they know when follow-up appointments are. Because sometimes clients, again, my memory's not the best. I might forget something. So ensuring that there's this one person, almost like a case manager usually, that's my role for these 4, 8, 12, 50 clients is ensuring that there's contact with everybody else that's involved, because it enhances the care. I think for a lot of clients too, it's one more thing that helps them recognize the importance of this. If this recovery home was doing this and emphasizing it, that's one more thing that will reinforce to me, hey, I should probably go to these appointments and I should take my medicine and I should do these things. But I also get to not every environment may have that ability or have that person or be able to do that. And that's where the real challenge can come, I think. Yep.
Yeah, yeah, I agree. I know when I first opened Recovery for Life, it was kind of at the time it was sort of providers again versus like probation and parole
Yeah.
or
Yeah.
versus, and I think sometimes that happens with recovery houses, right? And so thinking back to my own experiences of like when a client would test positive with us and did we notify the recovery house? That would be an important piece of information. Or if a client with co-occurring had a medication change, did we notify the recovery house so that they could be aware of it? And we didn't do that. And so that's something I think I wish that we would have done more of. So I think you're
Hmm.
right. Building those relationships with your community treatment providers, getting in there and letting them know that you want to be on the same team. And I think that continuity, like I know when we started to partner with probation and parole, it became a less punishing system and a hey, we're in this for your good, right? We're all trying to help
Right,
you.
right.
So
Well, and that you made me think of too, so much for our clients, having somebody that's going to advocate for them. Oftentimes we're the environment that they're with us a good part of the day, and we see things that a lot of probation parole, bureau of prisons, doctors, they may not see.
Mhm.
So being in that situation where we can actually advocate for them makes a pretty big difference. Yep.
Yeah. I think the other thing that I was the president of the Recovery Providers Association, which included recovery homes in Idaho for a multitude of years. And the other thing I saw that recovery houses really struggled with when they had co-occurring clients was medication.
Yeah.
Do you have any thoughts on that, on what rural recovery residents can do, or maybe housing policies that could better support residents who are prescribed with psychiatric medications?
Yeah, and so much of that too, I think, comes back to the individual environments. Do they have policies around that? I know a lot of them, it's the client takes their own medicine, but where are they stored? Do I have somebody that's at least watching that? Do we have defined times for med pass kind of situations? But having that, and it's just kind of one more example of, hey, we take this serious. You should take it serious too. And we just want to make sure you're okay. And, that also prevents things like, okay, now our six other clients taking somebody else's meds, which we definitely don't want. So if there's not some type of monitoring of it, and again, some programs, they can have a nurse. A lot of places can't, or some programs may have a case manager, others can't. So just trying to, in a policy standpoint, how are we going to do this that's structured usually makes a pretty big difference as far as adherence. If we don't have that, much greater chance that a client may go 4, 5, 6 days and not take their medicine. Again, self-determination, they do have a right to choose, but I think also, especially those level 4 clients that might have schizophrenia or bipolar disorder or a more prevalent mental health disorder, if they go 4 or 5 days and don't take their medicine, oh my God, that can really cause a major, they're going to fall back a lot and not only affect themselves, but affect the whole environment, unfortunately.
Yeah, yeah, I agree. I know I saw oftentimes recovery house providers were very hesitant or nervous to take clients that had
Hmm.
pretty severe mental illness
Yep.
issues due to the medications. I know one of the things that happened in Idaho is one of the recovery house providers opened a center where people could learn different skills and trades. And what they did was like the welder guys like welded these little medication boxes together,
Hmm.
and did a really inexpensive cost so that clients could keep their medications locked up, and they could be a little more closely monitored. So,
Yeah, that's a great idea.
um, I think one last question. I know you talked a lot about neuroplasticity, and I think that's a great thing. Any ideas around how rural recovery housing providers could integrate that in a low cost way with the clients that they're working with?
Yeah, and with that too, a lot of that also depends on the actual environment. Where is it? Access to surrounding areas. And I know sometimes too, we've come a long way with stigma, but recovery environments still deal with that depending upon where they are. But low cost, I mean, just getting out and walking. But even like having a defined time, and if there's a space where clients can kind of rotate through an exercise bike, some free weights, stretching, this. Listen, yoga, I mean, there's a lot of things where somebody can just put on a YouTube video and, all right, we're all going to get together and do 20 minutes of this. Anything like that, and a lot of that stuff is free, will enhance neuroplasticity, and ultimately breaking a sweat. Listen, gardening is a great one. I mean, a residential program where I worked, we had a client garden and they grew everything and picked it, and man, we'd have it for dinner. I mean, so they could take a lot of pride in that and all get involved as clients come and go. So usually you can get pretty creative with that. That really gets clients involved. And what I found is oftentimes the clients are the best ones to bring up ideas that you might not be able to do all of them, but if they give 5 or 6, you can definitely probably do 1 or 2, if not more. So, yep.
All right. Well, Jeff, we really appreciate your time today. Excellent presentation, some really important information. As the funding sources get scarcer and scarcer, then those funding sources tend to go to people who are sicker and sicker. And so I think if you
Mhm.
haven't run into people with severe co-occurring disorders, then I think you're going to in the near future. So great
Right.
information. We appreciate your time. Thank you everyone for joining us. And this presentation was recorded and the slides will be available in 2 to 4 weeks after the presentation on the Fletcher Group website. And we hope that you will join us next month when we're going to talk about actually it goes really well with this, the timeline for brain healing. So what does the timeline look like, and what does brain healing look like when someone's recovering from an addiction? So thank you, everyone. Happy 4th of July, and thanks for joining us.
Thanks, guys.